concerned, very simple, straightforward surgery, but you need to follow some protocols in the posterior polar cataract surgery. So, can you just play the video, please? Yeah.
Please, please start again.
Okay. Thank you. Thank you. Ophthalmologist from Tamil Nadu, and he had a posterior polar cataract. You can see that I'm doing a rexis, which is about 5 millimeter. Don't make the rexis too small or too big. Take-home pearls as far as the posterior polar cataract is concerned. And I'm doing a simple, straightforward surgery. But I'm doing a hydro delineation. Then I'm, as you know, these cataracts are very soft cataracts. I'm trying to use low phaco parameters and trying to chip and flip the nucleus and the epinucleus. Every time I come out of the eye, inject viscoelastic, preferably viscoat into the eye. Then I use a coaxial irrigation aspiration. Then all of a sudden I notice there is a pre-existing PC tear as well. Then inject viscoelastic and come out again and immediately shift on to the bimanual technique. Create a right side port, and go on to the bimanual, wherein the irrigation is separated from the aspiration. So then I find the vitreous, always remove the vitreous first. In this patient, I didn't use tricot because the patient had a family history of glaucoma. And every time I come out of the eye, you can see that I'm injecting viscoelastic into the eye and I'm changing the irrigation aspiration. After removing the vitreous, I remove the nucleus and the epinucleus. And going ahead, you can see the typical two pillars which are there on the posterior capsule, which is very typical of a pre-existing dehiscence in a posterior polar cataract. More importantly, you can see that the anterior capsule is very intact. I put a 3-piece lens, MA60 lens, and you can see that I'm trying to put that lens, the leading haptic, on the anterior capsule and tucking that with the McPherson, making sure that it is not going underneath the anterior capsule. And once I don't leave it in the sulcus like that, I do what is called the optic capture. This optic capture is very important to maintain long-term centration. I always suture all the wound's main port and side port. Just to show you a clipping of the optic capture. Once you put the lens in the sulcus, make sure that you use something like a Lester hook and tap that lens optic into the rexis margin. The end point is the ovalization of the anterior capsule or the capsular rexis margin. That is the end point for you to know. Make sure that this lens is locked. This prevent long-term centration of the lens, stability of the lens, and also prevent what is called UGH syndrome. You can see the postoperative visual acuity is maintaining even after 1 year. Now it's about 3 years follow-up, and the patient is doing very well. So this is a simple message I want to give for all of you for posterior polar cataract.
Very nice video, Mohan. Before we go on.